So now we are focusing on cats. And as I mentioned earlier, we are taking the information that we just reviewed in the previous lecture. So everything that you learned, now we're going to build on it and say what is cat specific. So you'll see some of the same slides, but then with a cat specific comment. So here we go with cats. By the way, that handsome fellow on your screen is one of my kitties. He's really good at posing for photos, so he gets to be in a lot of the presentations. So once again, my conflict of interest, I really do like to talk to companies that make or sell anesthesia and pain management products because I want to know about them and then I want to be able to share them with you. So I do all that's unique to NOCEDA. And then Onsior for us in the US is the only NSAID approved for repeated dosing in cats. Now, just a quick reminder, and it's not a real poll, you don't have to look for anything to click, but just to remind everybody about cats. Cats are not small dogs. And we talked about the anesthetic risk for adverse events, and we used anesthetic death as the ultimate adverse event. And we asked our cats at increased, decreased, the same risk as dogs or no risk. And of course, everybody remembers, we just talked about it, cats are at increased risk for anesthetic death. So now we're in the cat specific. Why could that be? But first, just a reminder. So the risk factor chart there and how much riskier anesthesia is for cats than dogs. And look at the healthy cats. Even the healthy cats double the risk of dogs, double the risk of healthy dogs. How could that be? Shouldn't they all be healthy? And then the sick cats, of course, even a higher risk. And in fact, sick cats are really among the highest risk patients that we anesthetize in the standard dog and cat practice. So, top 10 tip number one is to know what makes cats at higher risk for anesthetic death than dogs. And then we can go through more tips and talk about how to decrease that risk. Wouldn't it be fabulous if we could change the statistics so that cats are not at higher risk? So let's look at some of those risk factors. First of all, personality. We have a lot of cats that are really scared or anxious, like the cat on the left. And then if they have a really high level of fear or anxiety and stress, they might actually become fractious or aggressive. And a lot of times they're not that way at home, right? But that stress of coming into the hospital. And it's true that dogs experience this too. But if you just look at the species as a whole, there are a lot of just happy, not stressed dogs, all the Labradors, right? Happy to be at the clinic. And there's not very many happy, not stressed cats. So, as a species, a lot more likely to have that high fear, anxiety, stress. And remember, that will impact two things: anesthetic safety and the intensity of pain. I have to mention that again one more time just because it's so important. But this puts them at an increased risk because we have to have that higher dose of sedative and anesthetic drugs, and the adverse effects are dose dependent. Also, increasing anesthesia risk factor. So, that increasing ASA factor that we looked at in the previous slide with that chart of how sick the cat was and what that meant for the risk. And obviously, this would be the same in dogs, but of course, there is some cat specific component to this, and that is cats hide everything. They hide pain, they hide illness. So often, by the time we see those cats in our hospital, they are sicker than a dog might have been because the dog might be out showing, hey, don't feel very good. And the cat's hiding under the bed. So by the time the owner notices, they're at a higher ASA status. So we're anesthetizing often sicker cats that we wish we could have seen earlier. Also, small body size is a risk factor for anesthetic adverse events. And that can also be true for small body dogs, right? So the little terriers might have some of the same risk factors like hypothermia, the development of hypothermia. But again, there is a species as a whole. Yes, there are some small dogs, but there's a lot of medium to large dogs, whereas all the cats are small. So a bigger problem across the species of cats. Now, not only the not only does the small body size impact this next one, but also the fact that cats have a lower blood volume impacts fluid therapy. Remember, we need to give cats a smaller volume of fluids, intravenous fluids during anesthesia, than we give to dogs. And as I said, we will talk about all of these. Cats also can be more difficult to intubate, so we can damage the airway, and that increases the risk for anesthetic complications, obviously, if we're causing damage. And then cats can have species specific metabolism. So when we're talking about analgesic drugs, acetaminophen comes to mind. So cats absolutely, of course, cannot have acetaminophen, or cats can have specific species responses. Like with opioids, cats are often more likely to get excited and dogs are more likely to get sedate. So it changes then how we might utilize those drugs. So just remember our continuum: home, hospital, back home, and utilizing the owners to, sorry, I probably went too fast with the quote there, but utilizing the owners to help us get that safe anesthesia and pain management started. So thank you for somebody asking about the trazodone. The dosages are there on the slide. And the upper end of those dosages may scare some people. They might say, you might say, that's a lot higher than I usually use. And if you're using these drugs to modify cat behavior, so keeping the cat at home, trying to make it be calmer, not be so nervous if company comes over or if it has to get in the cat carrier, yeah, we probably don't need that really high dose because we don't want to sedate cat at home. Remember what we're talking about in this presentation, though, and that's getting the cat from home to the hospital. So sometimes it takes that high dose because that's a very high stress situation. But also, they're coming in, if they're coming in for me, they're usually coming in for anesthesia. So a slightly sedated cat, or at least a very calm cat, is absolutely fine, right? That's how I want them to come into the clinic. So those higher dosages are often necessary. Plus, some cats just really have a high level of fear, anxiety, and stress. And yes, you can use trazodone and gabapentin together. So if the gabapentin at a high dose isn't working, like it's okay, but you need more, drop back to the middle dose of that gabapentin and add the trazodone to it at the middle dose. And often what you get is a more consistent response. So I do use them together. And then don't forget just making sure that we get them on board on time, that they really work. These are slower onset drugs, so we want to make sure that kitty has the drugs. And I meant to bring up when you asked the question before about dosing for several days, this nighttime dose, this consider dosing the night before. If they have even moderate fear, anxiety, and stress, it is really helpful to start that dose the night before, not just the morning of. You just get a more consistent serum concentration of the drug and a more consistent response. And yes, somebody asked about evidence. That's again why we can really talk about it in cats. We have this study on cats that receive gabapentin prior to a veterinary visit. So the owner assessed cat scores during transportation and the scores during the veterinarian the scores during the veterinary examination were assessed, and cats that had gabapentin had significantly lower scores, which means lower stress in transport, lower stress in handling, so better compliance, and no adverse effects from the gabapentin. What adverse effects would I watch for? I think we all know, but just to repeat, the sedation. And we don't want sedation at home long term. We wouldn't use the higher dosages, but sedation, mild sedation. We don't want to deeply sedate a cat at home, but mild sedation coming into the hospital isn't always a bad thing. We can adjust our anesthetic dosages based on how sedate that cat gets. So yes, we do have the efficacy and safety studies, or at least a study. I don't have a study on trazodone in cats. I don't think there's been a recent publication, and certainly I haven't seen one. But I commonly use trazodone clinically in both cats and dogs, and can tell you it also works, and no adverse effects except maybe sedation. So if gabapentin is not working, don't at all be afraid to try trazodone or try them together if you need to. We kind of seem to just use trazodone in dogs and just gabapentin in cats, and it doesn't at all have to be that way. So back to why that's so important. It's about anesthetic dose. So we want to keep that dose low. So it's about anesthesia, but it's also about pain management. We don't want that pain and anxiety vicious circle, right? So the more painful they are, the more anxious they are. And the more anxious they are, the worse that pain is. So we want to make sure that we're addressing both in our patients. And cats hide pain. So it's something we often have to start doing more pain focused exams, pain focused questioning to find the pain in cats. So we have to work a little harder in cats. Oh, sometimes a lot harder in cats to find that pain. But if a cat seems to be doing a either do a pain exam, ask good pain questions, or and not a or and. So we're going to do pain exams, ask pain questions, and notice if the cat just seems unusually anxious or stressed. It really might be pain. And then, of course, to reiterate, don't forget we want to use our gentle handling and utilize our nurses. And all of our nurses, I think, should be trained in gentle handling. It's the nurses that spend the most time with the cats often. And so, starting from the very beginning of keeping that cat calm and working with it in its carrier, having it wrapped in a nice warm towel, using the pheromone spray, because we know there are a lot of things that we can do just with gentle handling. But then, of course, really watching that cat. And if things start to escalate, because of course we all know that cats have kitty minutes. How many minutes can we keep them calm? And it's usually a fairly short number of minutes that to keep the cat calm. So we don't want to use up all of our kitty minutes and then have a bad situation. So especially if that cat is going to be anesthetized anyway, if it starts to get more excited, more fractious, sedate it before it gets out of control. Because what happens if we wait till that cat's really excited, again, that high dose of sedative drugs, and we're trying to keep our dosages low. So, quick review the pain pathway. I can never give a lecture without showing the pain pathway. So, you get it again. Pain starts out in the periphery in that process, of course, of inflammation, especially acute pain, right? With chronic pain, there can be changes, specific changes in the pain pathway that develop. But really, with acute pain, lots and lots of inflammation. So we want to think about anti-inflammatories in cats, and we've already talked about some cat specific drug, which we'll look at again, and then also timing for administration of the local anesthetics, but we or local anesthetics. That's the next one of the anti-inflammatories, but we really want those drugs on board. Now, how about local anesthetics? As I mentioned in the previous lecture, one of the most powerful classes that we have. So we want to look at cat-specific blocks. And then, of course, we would have opioids for the pain level at the spinal cord and in the brain. And then that descending inhibitory limb more for chronic pain, but opioids work there as well. So let's look at our checklist. Just a reminder, where are we putting those drugs? We talked about the anti-inflammatories preemptively if it's the right patient. Opioids, of course, alpha 2 agonists are sedative analgesics, so they're a good addition for that multimodal part of pain relief. Induction, not always the time we think about analgesia, but sometimes we give a bolus of opioids in that time. And then maintenance, of course, the blocks, the constant rate infusions, and just boluses of drugs as well. And probably everybody probably has this patient every day where maybe you are an hour and a half into the procedure, and suddenly the nurse says it's a lot more difficult to keep the patient asleep. It keeps waking up. You have to turn up the vaporizer, and then the patient gets hypotensive, right? So it's that vicious circle, and the nurse is really struggling. Don't forget, during that maintenance phase, you might need to redose your opioid. That's about the time that the opioid might have worn off. So if you're in there, kind of getting close to that 2 hour mark, because we usually say that morphine and hydromorphone and methadone last somewhere between 2 and 6 hours. So 4 hours is our average, but it's not always 4 hours. And especially when pain is intense, like in the middle of surgery. So if anesthesia is getting difficult, consider redosing your analgesic drug. And then, of course, we continue our analgesics into the recovery phase. Don't forget analgesia in recovery and then in discharge as well. Okay, so tip number three, top 10 tip number three is to utilize cat specific drugs whenever possible. And there are some analgesic drugs there that are cat specific. And this isn't all of the drug. We're not trying to represent every drug that might be cat specific, but just an example of some that are. When the drugs are specific for a species, luckily we're talking about cats and this one my favorite, but when they are specific for a species, that means that research has been done in that species to prove efficacy and safety and to give us some guidelines on how to use those drugs safely. So we know that there's this very robust science behind these drugs that have gone through that approval process, so we can feel very confident using those drugs. So one of the drugs that's cat specific that we mentioned in the previous presentation, and now we want to explore in a little more detail, is Onsior or robedacoxib. And remember that it is approved for control of postoperative pain and inflammation associated with orthopedic surgery, ovariohysterectomy, hysterectomy, and castration in cats. And the oral is approved for cats 5.5, greater than 5.5 pounds and greater than 4 months of age for only 3 days, right? Not only for 3 days. That's great. We can send it home. The injectable also approved for a maximum of 3 days, same label claim in the US, in cats greater than 4 months of age. And the great thing, as we mentioned before, this is fantastic. We can combine that time frame, or we can condense that time frame. So it's still a total of 3 days, but we start with the injectable NSAID, and then we send home that oral NSAID to be given once daily by the owner. So it's really a great way to provide a continuous level of an anti-inflammatory drug. Of course, as we mentioned in the last presentation, so just quickly again, anytime we talk about the efficacy of a drug, we also need to talk about safety, because every drug has two sides of that coin. So we talked about that a little bit in the last lecture, but again, just kind of a few highlights: not giving an NSAID along with the steroid, teaching the, telling the, communicating with the owners the adverse effects of that drug, what to watch for so they can stop administering the drug if that adverse effect occurs. And then again, not all drugs are studied in all patients. So which patients have been evaluated and which have not are on that label dose. So the example here, it's not been evaluated in cats used for breeding or those that are pregnant or might be lactating. This full information is on the product insert in the box that Nocita comes in, that Onsior comes in, and also on the Elanco webpage, product webpage. Let's talk a little bit more about Onsior, though. It's definitely a very effective and interesting drug. It does have fast absorption, and that's incredibly important because we want to start providing analgesia as soon as possible, and especially if we are waiting until the post-operative period to give that drug. And we mentioned in the last lecture that sometimes we want to do that, so we really need that fast onset. It also has a rapid clearance, so it's not staying in the blood, which is perfusing all of the organs. It's actually going to the site of inflammation, which is in the next slide. And elimination is primarily via the biliary route. Okay, so back to getting out of the blood and going where we want the drug. Remember, NSAIDs, it's not about how much drug is in the blood binding to receptors. That's not what we want. We want it to go to the site of inflammation and stay there. We don't want it in the blood perfusing the other organs. And so we know that the Onsior is rapidly absorbed, as we said, and also that it goes to that site of inflammation. NSAIDs are highly protein bound drugs, and at the site of inflammation is a lot of protein. So the NSAID goes exactly to where we want it, and it stays there. So it's fantastic. And then it's rapidly eliminated for the drug by the blood. So you can see why NSAIDs like Onsior are an ideal analgesic drug. They go where we need them to go. And we've said already, acute pain, almost all of acute pain that I know starts with inflammation, whether it's surgery or trauma. So we want to get those anti-inflammatory drugs in the cat when we can. It might be post-op, but at least we're preventing further inflammation and decreasing the inflammation that's already there. So what kind of local blocks might we be using in cats? Honestly, any of the blocks that you saw in the previous session, I had the whole long list of blocks. But the ones that I think we might be using the most, the oral or dental blocks. So we see up here at the top, caudal maxillary, caudal mandibular block being done from extraorally. And that's it's the lower left-hand corner is that mandibular foramen where we're trying to direct that needle towards it. We're not getting it in that foramen, just towards it. And then here, a maxillary block using the infraorbital foramen as our landmark. So I didn't get, not going into a lot in dental blocks. You're probably using those already. And you have a whole nother session specifically on the drugs. So I can't talk about all the drugs because then you'd have everything twice. And I have more to say about anesthesia and pain management. Two of the ones I use very commonly in cat three, sorry, in the middle here, that's indicating a sacrococcygeal epidural that we use a lot for unblocking cats with urethral obstruction, but we certainly don't use it just for that. Anything in that perineal area, so obstipated cats, tail amputations, really anything in that area, this block is very, very useful for. So love that one. The top is peritoneal lavage, where we're seriously just squirting local anesthetic into the peritoneum, into the peritoneal cavity after ovarian hysterectomy or other abdominal surgeries. And I think you'll hear more about that one coming up as well. I use that one all the time. And then, of course, the testicular blocks. I think so what we're showing there at the bottom is the testicular block, and just injecting that drug directly into the testicles is such an easy thing to do. And I'm going to tell you, I have heard lately people say, yes, I use that testicular block for castration in dogs, but it's contraindicated in cats. And that is not true, not true at all. And in fact, I think it's more important in cats than dogs. Okay, it's important in all of them. But it goes back to a question from the last session when the question was, how do we get the drugs in the cat at home when it's difficult for the owners to give them? And we know it's not always going to happen. So we want to do the best we can to educate the owners, but we also want to do the best we can for the pain level of that cat. We want it as low as possible before that cat leaves the hospital. And one way to make it as low as possible is to utilize all of the drugs we have, the multimodal analgesic drugs, and the local blocks are a big part of that. So please, please, please do these blocks in cats. Very, very easy to do. And again, effective and maybe more important in cats than dogs. These are the dosages that you might be using for all of the local anesthetic drugs, the dosages, and then the time to onset and the duration of action. And remember, lidocaine is the fastest onset, but also the shortest duration. Ropivacaine and bupivacaine kind of have, they're very similar, and they have a slightly longer duration of time to onset than lidocaine, but not really long. I think some people think it takes up to 30 minutes for those drugs to work. And no, it doesn't take that long for the drugs. 10-ish, maybe 15 for full onset, but rarely would it take 30. You would have to be really far away from the nerve, I think, for it to take that long. And let's talk about the constant rate infusions for acute pain. And I use these for surgical pain and for trauma pain and sometimes even chronic pain, but we're talking about acute pain in this session. And of course, we commonly utilize opioids and ketamine in our constant rate infusions. And it's a great way, as we talked about last time, to have that stable plane of analgesia. Sometimes we use alpha 2 agonists like dexdomitor for a CRI because we get some calming and some analgesia. Lidocaine is the question, isn't it, with cats? Because all of these other drugs, there's no concern in cats, but lidocaine, we had to kind of decide about cats. So we know that lidocaine infusions did provide acute pain relief in cats, as evidenced by the fact that we could decrease the dose of the isoflurane when the cat was getting a painful procedure, right? We could still decrease that dose if there was a lidocaine infusion. So it works. But in that same study, it did cause some decreased cardiac function. And so that's kind of a bit frightening, isn't it? If we're decreasing cardiac function. So is it safe or not? And then this study came out that said that isoflurane definitely changes the pharmacokinetics of lidocaine and slows the clearance So maybe it's sort of causing an overdose, an inadvertent overdose. So maybe it's because they're anesthetized. It's not just the lidocaine in the cat. And then this is where we're at right now. So I'm going to tell you that I do use lidocaine CRIs in cat. It's cats at the very low end of the dose, usually in conscious cats for pain like pancreatitis pain is one of my favorites. So I'm comfortable doing that, but you have to decide for yourself how you feel about lidocaine infusions in cats because there is that confusing evidence. Okay, we are at top 10 tip number 4, and that is don't put a cat in a box. Like the cat, we should not be inducing cats this way. And there's an old myth that this is the safest way to induce cats. And in reality, this is quite dangerous because it's a very high dose of gas and the adverse effects are dose dependent. So those cats can get really hypotensive. They're often crashing around or they're just frozen. And when a cat is frozen, that's a very high level of stress. And so that takes a higher dose to get them anesthetized. We're trying to keep the stress low in the cats. And so it just gets worse and worse, and it takes a long time. We don't have an airway. So just really not a good way to induce cats to anesthesia. And here might even be the bigger issue for some of you. For me, it's the cat and the staff. They're equal. But don't forget that constant exposure to inhalants, probably to any chemical, can cause adverse effects in some humans. And so we know that humans that have a sensitivity to the gases might develop migraines or might have immunosuppression. So we really don't want our staff exposed either. Okay, top 10 tip number 5, be careful with the endotracheal tube. So it's back to the risk factors that might be contributing to death from that data we started with in the previous study. And so we said the sicker they are, the riskier it is. If they're geriatrics, thank you for somebody asking that last time. Yes, there is a slightly higher risk factor. So we want to make sure that we are anesthetizing geriatrics, but we have that dedicated nurse and we're really watching them. Extremes of weight, because really thin patients are likely to get cold so fast. Fat patients, we might not dose on lean body weight, and we should. And then fat patients also have a harder time breathing. If the procedure is an emergency or really long, those can impact anesthetic safety. The use of inhalant anesthetics alone actually contribute to increased anesthetic death, as we said in the previous slide. And then endotracheal intubation, why? And I'm going to ask a question. Do endotracheal tubes contribute to death in cats, or is it humans that don't know how to use the endotracheal tubes contributing to the death? It's the humans, right? It's easy to damage that larynx and trachea. So here are some tips. Utilize a stylet and a laryngoscope when you are intubating cats so that you can really see when those arytenoids are open. I know every nurse out there can intubate a cat without a laryngoscope, but I want you to watch those arytenoids. Put the drop of lidocaine on each arytenoid so that decreases the spasm. And because it's just a drop, that's in addition to any local anesthetic that you might be using for a local block, right? It's not enough to decrease your local anesthetic dose. And then I know this is crazy because no anesthesiologist ever has said, make the cat deeper, right? That's not what we do. We're always decrease the drug dose. But if there is laryngospasm, often it's because that patient really isn't anesthetized. So give them a little bit more propofol, give them a little bit more alfaxalone, whichever one you're using, and get those arytenoids relaxed. So make them a little bit deeper. And then be very careful when you inflate the endotracheal tube cuff. You want to push down on your pop-off valve button, which is much safer than closing this pop-off valve. So if you don't have a button, I encourage you to get a pop-off valve button and then never, never, never close this valve. Push the button down, squeeze the bag to about 15 centimeters of water on the manometer if you have one on your machine. So the manometer is here on the side. And then continue to be careful with that endotracheal tube. In this study, 20 cats were identified with tracheal rupture. And just shout it out loud. Just guess. You can shout it in your head or you can shout it into space. What do you think those cats were anesthetized anesthetized for? What was the procedure they were anesthetized for? 70% of the cats had the same procedure. I hear you already. Yes, dentistry. And the problem is twofold. One is we often inflate that cuff too much, so it's really putting a lot of pressure on the tracheal mucosa. And then if we don't disconnect the patient from the breathing system, if we're moving it, there's the endotracheal tube. And so disconnect, flip the cat, reconnect the breathing system. If we don't disconnect, the tube is pretty stationary, but the breathing system is going to kind of go like this, but it makes that tube rotate in the trachea, and that cuff can then tear the tracheal mucosa. So don't overinflate the cuff, and definitely disconnect the cat when you are flipping it over. Top tip number 6, everybody knows this, but just in case there's anybody that doesn't, we have to say this one, especially because we might be utilizing this tool while we're doing dentistry or dental blocks. So this could be associated with pain relief, and it shouldn't be. So I want to show you some cat anatomy here and tell you why we should never, never, never use these rigid mouth gags, these spring-loaded mouth gags. So what you're seeing on the screen, this is a cat's CT. So there are the eyes here, the nose would be up here. And this white bit is dye flowing through the maxillary artery. And it's the maxillary artery in the cat that supplies parts of the brain and the retina. In the dog, it would be the internal carotid, but in the cat, it's the maxillary artery. And if you look over here at the maxilla, there's a mandibular. So we're looking at the mandible. It is the maxillary artery. The mandible, cats have this funny little bony process on their mandible. Dogs don't have that. Here goes the maxillary artery. And if that cat's mouth is propped open, fully open with that mouth gag, this little bony process can occlude that maxillary artery. And obviously, it doesn't happen in all cats, where we would see a lot of cats that are blind or have central nervous system deficits like neurologic deficits, so they can have seizures, they can be obtunded, they can really in a lot of different central neurologic conditions. And probably everybody's seen it once, hopefully never, but it's because of that decreased oxygen delivery to the brain. So you can see there in the middle of that dye circle, there's nothing there. There's no dye, there's no blood flow to the brain, that parts of the brain and to the retina. So we want to make sure that never happens. So don't use that mouth gag. Top tip number 7 is really monitor these cats carefully. The smaller they are, the harder it is to monitor, and then the more important it is to monitor. So let's look at small body size and how that can increase anesthetic risk. And first, before monitoring, I want to talk about drugs, and that it's a lot easier to overdose these really small patients, dogs or cats, because if the dose is 0.1 mils and we accidentally draw up 0.11, which we wouldn't, but if we did, that's a 10% overdose, right? It doesn't look like much in the syringe, but that's 10%. So we want to be really careful with dosing. And then, of course, the monitors, it can be very difficult for the monitors to, I'm going to put all that up there, for the monitors to find sometimes the really small variables it's trying to find. So the blood pressure cuff may not work in a really small cat, and maybe the blood pressure is fine, maybe it's not, but the vessel is just so small that that poor blood pressure monitor can't find it, and the pulse is really small. Or for pulse oximeters, the pulse is really small and the cat is cold, so it's vasoconstricted. So this is why we really need to be very diligent with our monitors, and more important than that, every cat needs a nurse, because when the monitors aren't working, I want the nurse with hands on the cat. And yes, I can feel the pulse fine, even though the machine can't pick it up. The cat is peeing. The capillary refill time is normal. The cat is breathing, right? Sometimes, not sometimes, every time the nurse is the best monitor, but especially if all your mechanical monitors aren't working. And again, it's not that the cat's blood pressure is necessarily any different from the dog. It's just that the monitor can't pick up that really small vessel. Oh, and back to the just really quick, physiologic support, as we'll come to, must be cat-sized. So that's a little preview. So just one study on blood pressure that I wanted to, I don't know which direction to go, that I wanted to share with you guys, probably everyone's familiar with this study on Doppler measurement of blood pressure. And what we know is that the Doppler, especially, but it can be any indirect blood pressure monitor, actually underestimated systolic blood pressure. So it was higher, the systolic blood pressure, if there was direct arterial catheterization, which most of us don't need to do on a daily basis. So the Doppler said it was actually lower than it really was. And but it did identify trends up or down. And really, it's the trends that are most important. Is it low and we're making better, or is it high and we're making it worse? So the reality is that systolic blood pressure that the Doppler says it may be closer to mean arterial blood pressure. So if it's 80 and we know we want it to be 90, here's my tip to you though, don't just assume that it's closer to mean. Some people even say that the first sound you hear with the Doppler is mean arterial blood pressure, and that's not true. It's not that close to mean, but it might be somewhere in between. But just assume it's systolic blood pressure and do make some manipulations to improve that blood pressure, a little bolus of fluids. We'll come back to that. Decreasing the vaporizer would be the first thing, and see if there's a response in that cat. So don't just assume it is mean arterial blood pressure. Hypothermia, we've already talked about all of the negative things that can occur with hypothermia. And like I said, I don't have any like super secrets, but 2 tips: start warming at induction as soon as we induce that patient to anesthesia. That patient is vasodilated, so it's losing more heat. The thermoregulatory center is part of the central nervous system. It's anesthetized now, just like everything else. So it's not doing anything to help improve that blood pressure like vasoconstriction or shivering. And then we shave hair and we scrub them with fluids. So we do a lot of things to make that patient cold. So start warming right at induction and minimize anesthesia time. The longer patients are down, the colder they get. Now, I want to show you this cool study because it's kind of hot off the presses. This is a 2020 study. And you can see in this study, they bubble wrapped cats. They bubble wrapped their thorax and their legs for ovarohysterectomy. And I don't know if this is the answer or not for every cat, but it worked in this study. And I want to show you the impact of keeping cats warm. So you see there the cats, the wrapped cats are this column, and unwrapped cats the other column. Look at this, the cats that were unwrapped, they dropped to 36 degrees Celsius even before the surgery started. This was just for clipping and scrubbing, they're already dropping. The cats that were wrapped didn't get down to 36 until the end of the surgery, so it took some time to get that cold, so it really did help. And then look at the difference in recovery times. 26 minutes to standing, this isn't to extubation, it's to standing. 26 minutes in the warm cat, 47 minutes in the cold cats. That's a huge delay in recovery. And remember, recovery can be problematic. So we're going to come back to why we'd like them to be recovering more quickly than that. Okay, so let's go back to our risk factors for death, and fluid therapy is on that list. And again, why? Is it really fluids that are dangerous to cats, or is it people with fluids that are dangerous to cats? It's people with fluids that are dangerous to cats. And if you think about it, if we look at what the average blood volume of a cat is, it's much lower than dogs, right? And so the recommendation for IV fluids is really only 3 mils per kilo per hour. Now that's the base rate. We would add more if that cat was hypotensive or losing a lot of fluids, right? Hypovolemic, but that's only 12 mils per hour in your average 4-kilo cat. And I don't know about you, but if a big bag is just hanging there, a liter bag, I can't tell if 12 mils has gone or not. I mean, it could be 50, it could be, I could probably figure out 100, but 12, you can't see that. So my advice to you is use a syringe pump or use a burette, some kind of a chamber, a smaller chamber that's connected to your IV fluid line, to your the IV fluid bag, or even just draw fluids up in a syringe and intermittently give them to the cat as you take the physiologic readings. The fluid rate doesn't have to be continuous; it can be intermittent. It just has to not be too much. We need to be careful with fluids in cats. So then number 8, top 10 tip number 8, we're almost done, is don't drop your vigilance in recovery. We've already seen this slide that most anesthetic deaths occur in that recovery period. So back to keeping them warm, we don't want a long recovery period. We want them proceeding nicely through recovery and waking up and getting warm and getting their analgesic drugs. Top 10 tip number 9 is really quick. Pain score your patients. And you are in for a real treat because the final 2 sessions in this series of webinars is on this feline grimace scale by Dr. Paulo Stegall, who's one of the authors of the grimace scale. So we're not going to go through an example because you are going to have a lot of amazing examples. You will all be pain scoring cats if you're not already. And then winding down to top 10, tip number 10, don't forget to discharge the cat with analgesic drugs. Pain does not end just because that cat leaves the hospital. And we know all of the adverse effects of pain on health, behavior, and welfare. So we want to make sure that cat has low pain level. And remember that to utilize that balanced comprehensive analgesic protocol, because drugs that we administer preemptively can help decrease that pain level, like the NSAIDs, but even the opioids, anything that help keep that pain level from escalating. We know the local blocks play a major role, and then of course long-lasting local blocks like Nocita actually are still there in recovery. And then of course our NSAIDs, and this may be the time we start them, and we said last lecture that's absolutely fine. We just want to keep to those 3 total dosages, and so we want to continue that analgesic level. So that is it for the cat tips. And I tried to leave a little bit more time for questions this time, and I might have succeeded. So let's see how we do. I think we are ready for questions, Dr. Archer.
We do indeed, Dr. Grubb. We've got a lot again. Really good practical presentation, and it's resulting in a lot of practical questions as well. So starting off with general pain protocols for routine surgeries. And this sort of groups under quite a few questions as well, linking into non-steroidals, local anesthetics. So you mentioned that more analgesia is required for invasive surgeries and potentially even for the routine surgeries. So can you comment on whether we should be giving something additional and what your recommendations would be in those scenarios?
Absolutely. That's a great question. And thank you for the practical questions. That makes me know that you are going to do this, right? So then it's absolutely true. The more invasive the procedure is, the more tissue damage there is, then the more painful that patient is. And it makes sense, doesn't it? Because either there's already tissue damage, like an orthopedic procedure, like a fracture, or maybe we're kind of adding to that tissue damage, like we're really having to do an exploratory laparotomy and manipulate the tissues in the abdomen to find whatever we're looking for, an obstruction maybe. Whereas an ovarohysterectomy, which is painful, it is a major abdominal procedure, but we don't have to do quite as much tissue manipulation. So it's less painful. And, you know, speaking of ovarohysterectomies and castrations, we call them routine procedures because they're routine for the surgeon, but they're by no means routine for the cat. Again, we are going in the abdomen and pulling out some tissue and crushing some other tissue, but still probably less painful than an exploratory laparotomy. So for me, a multimodal analgesic protocol for any patient would start with those opioids preoperatively and NSAIDs if that's appropriate, and an alpha-2 agonist if that's appropriate. Again, that's multimodal analgesia. For that maintenance phase, again, giving more opioids if we need to, certainly using local blocks. I use local blocks in every patient that I can because of that unique and powerful mechanism of action. We should never leave the local blocks out. And then in recovery, maybe another dose of opioids or alpha-2s, and then discharging with NSAIDs, plus whatever that patient needs. If this was an abdominal exploratory that we just described, or certainly if it's an orthopedic procedure, then I would add some more analgesic drugs in that maintenance phase, starting those CRIs along with the local blocks, and probably maybe giving a higher dose of opioids to start with as well. So using dose and different drugs to really fill out that protocol. And also knowing at that higher level of pain that we'll have to be more aggressive postoperatively and after discharge. So not just sitting home with just NSAIDs or NSAIDs and buprenorphine, but NSAIDs and buprenorphine and something. But that's the problem, isn't it? The biggest gap that I see in effective analgesic protocols is that we don't have very many, we only have one, and it's going to surprise you which one I'm going to say, but we don't really have drugs that cover the time when the patient is painful in the hospital to ready to be discharged medically, but they're really not ready to be discharged on a pain level. Let me just give you an example. So an orthopedic patient that we'd had on a CRI, and it's ready to go home, right? Everything else is fine. The surgery's done. The patient's awake. Everything's going normally. We can send that patient home, but it's probably not going to go home on CRIs, but it still needs those CRIs. It's not ready to go home on NSAIDs alone, or a cat with NSAIDs and oral transmucosal buprenorphine alone, right? That's still not enough really for orthopedic pain. And we don't have the right drug to fit in there, except for, this will surprise you, Nocita, actually. So we're always looking for opioids or something we can give orally. Don't forget, if we use Nocita, then we've got that 72 hours. So we are technically discharging the cat with local anesthetics, not for the owner to give, but it's in the cat. So then we could have the buprenorphine, the local anesthetics, and the NSAIDs. And we really, the higher the pain level, the more aggressive we have to be. And remember, that means through all phases of pain relief, because the better we are with that balanced multimodal protocol, the lower that pain is postoperatively. It's not just about the postoperative drugs, it's the whole thing. So think about the pain pathway and utilize your drugs then in your balanced protocol.
Okay, thank you. And working with that as well, a few sort of the problem or more worrisome considerations. So cats with chronic kidney disease, for example, and also any recommendations for cats with pancreatitis, and also dental, particularly the at-home administration protocols with the sore mouth.
Oh gosh, yeah. So it was chronic, wow, chronic kidney disease. And then was there one in the middle? Because my sound goes out to
Pancreatitis.
pancreatitis. Thank you. So chronic kidney disease, that brings up several concerns, anesthesia and pain management. And really for those cats, we absolutely don't want stress. And I'm going to say the same thing for pancreatitis cats as well. That we don't want any stress, and pain is stressor, and stress exacerbates endocrine diseases like pancreatitis, exacerbates some of the negative effects that might impact the kidney, like vasoconstriction. All the stress responses might impact that kidney. So keeping really focusing on keeping the pain low and the stress low. So with chronic kidney disease cats, I really want that gabapentin pre-anesthetically, or trazodone, keeping them calm. Remember, cats clear gabapentin partly unchanged through the kidneys. And so we do want to be careful with the dosing, though, because we don't want a really sedate cat at home. I've told you a little bit sedate's okay. So dosing appropriately. And then those are cats with chronic kidney disease. I do use NSAIDs in chronic kidney disease cats for the control of chronic pain. But I agree with everyone who's nervous, this acute insult to the kidneys with the anesthesia and the potential that the oxygen delivery might be lower during the anesthesia phase. I don't utilize the NSAIDs for that perioperative period. So I take them off about a day before and then don't start them back until about 2 days after. So we're missing that NSAID. And anytime we take away that NSAID, we have to try really, really hard. We have to be very aggressive with analgesia. So in those cats, even if it was what we were thinking would be a minor procedure, I would add that constant rate infusion to the protocol, because we've got to do something. We can't just take the NSAIDs away and not try to change the pain level. So then I would pre-medicate with the opioid, definitely run a CRI intraoperatively, probably more opioid, use those local blocks, making sure I got the local blocks on, trying to use the Nocita, and then post-operatively the Nocita and oral transmucosal buprenorphine, and maybe gabapentin, depending on what the surgery was, what the source of pain was, it might help. But yeah, we just really have to be more aggressive. And then just on the anesthesia side, keeping that blood pressure good, right? Keeping that oxygen delivery to those kidneys. So it is harder. We have to work harder and use more multimodal. Pancreatitis, we underdiagnosed. I don't know, I shouldn't say that. I know I underdiagnose it. There's a lot more cats, I think, we really start looking for it that had pancreatitis and we think, and it's very painful. And I do like the lidocaine infusions for that. And I'm not worried about the isoflurane, but you have to decide. You might be afraid of lidocaine infusions altogether. And then certainly we can just give systemic opioids, intermittent injections, or you could do some other infusion like an opioid. I am a person who does give one dose of anti-inflammatory drugs in patients with pancreatitis to control that inflammation. Some people are probably going, yeah, me too. And some people are going, absolutely not me. There's no hard line either way, but that was just my take on it. But those cats do need analgesia. And then the last one was, oral administration.
Gentle.
Oh
Yes.
man, I wish I had an answer for you guys, and I agree with you. Those are the hardest. And again, if we can utilize systemic drug, or not systemic, but drugs the owners don't have to give it all, like the Nocita, that really helps. What I try to do with the orally administered drugs, try to get the cat to eat them so that you're not having to manipulate the mouth, because right, it's not the drug that's the problem. It's like holding a cat like that. I probably didn't need to demonstrate that, and that is the biggest problem. So sometimes we'll decrease their food intake at night, for instance, and I do this with gabapentin, even with Onsior, the little tablet. So decrease their food intake so the next morning they're hungry, and then put some treats with their Onsior or their gabapentin so that they'll eat it with their treats, and that can help. Some of the drugs, the liquid sometimes is better, like liquid gabapentin I like a little bit better. But it is difficult, and the best way is to see if you can get the cat to eat it or have it administered in some other way, which I know isn't easy.
Yeah, and we're at time. Just one quick question on the local anaesthetics. So I don't think it is a quick question. Your opinion of mixing bupivacaine and lidocaine in the same syringe. So talking about the quick onset, longer lasting.
Yeah, I'll try to make it quick. The really quick answer is I don't know either. But the thing is, like whoever asked that, we've always done that. Lidocaine fast onset, bupivacaine long duration, great combo. And then there were some studies from human medicine that came and said, no, 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 no. What you get is not the fast onset, not the long duration. It's a terrible combination. Don't do it. But not all the studies showed that. Some studies still showed that it worked that way. But I think a lot of people said, no, no, we can't do it. And then not too long ago, Dr. Peter Pascoe from the University of California at Davis published a study, and he is a brilliant anesthetist. He combined lidocaine with bupivacaine for dental blocks, oral blocks. And lidocaine alone, fast onset, short duration. Lidocaine plus bupivacaine, fast onset, longer duration than the bupivacaine alone. What he didn't study was bupivacaine alone. So it might even be longer if we just use the bupivacaine. So I try to not mix them and just build in about 10 minutes for that bupivacaine to work. It's faster than we think. So do a rough scrub, do the block, teach the nurses to do a lot of these blocks, and then cut. If you really have to cut right away, at least from Dr. Pascoe's study, I feel confident saying that the combo gives you longer duration than lidocaine alone and that fast onset. So maybe not as long as bupivacaine alone. So try to use the bupivacaine alone if you can until we know better. But Dr. Pascoe's study showed you can mix them.
Okay, we're unfortunately out of time, Dr. Grubb. There's still loads and loads of questions, so we will be getting back to try to answer everybody in person after this series. But just want to thank you for an outstanding presentation. You can see from the number of questions, the interest, and how practically relevant it is. But we'll let you go and continue your day as we change speakers. So
yes. Absolutely. So I will get my PowerPoint down, and thank you everybody so much. So excited to be with you. And thanks for all the questions. And I'm glad we could start this with anesthesia and acute pain management. And now you're in for a real treat because it's going to be nursing care with pain in cats by one of my really good friends, Donna, a very good veterinary nurse. And then Dr. Mark Epstein and Dr. Paula Stegall. You've got a great set in front of you. So keep the questions coming. We love them.